Hi guys. Okay, so I'm back with care of the patients with cancer, and this is chapter 22 in our book. Um, and so we'll start there. So our student learning objectives are to prioritize nursing interventions for patients with cancer, work with members of the interdisciplinary team to decrease the psychosocial impact of cancer, prioritize care for patients receiving chemotherapy and radiation, teach patients and families how to manage side effects, of cancer treatment, and how to protect yourself and others from cytotoxic agents and radiation. General disease related um, coincidence of cancer would be impaired immune and blood producing functions, altered GI functions, altered peripheral nerve function, monitor motor and sensory deficits, pain, and altered respiratory and cardiac function. Impaired immunity and blood producing function can occur when cancers invade the bone marrow, causing anemia and thrombocytopenia. Alterations in the GI function can cause, because of the increased metabolic rate and the need for nutrients, cancers can cause loss of appetite and also alterations in taste. But if you have a cancer that is fast growing, it will increase in the metabolic rate. Um, Changes in peripheral nerve function include this is most commonly seen as a side effect of chemotherapy, but it can happen with spine tumors, can cause peripheral nerve issues as well. But most common cause is because of chemotherapy. Motor and sensory deficits, cancer, and just so you know, in my notes, you'll see CA every once in a while. CA is a known abbreviation for cancer, and I apologize. When I chose to share my notes, I didn't catch all of them. I'm seeing that as I'm reading now. Cancer invades bone and brain and can compress nerves, and that can affect both motor and sensory functions. Pain. Cancer pain is best managed by an interprofessional team. There can be all kinds of different, not just pain management from opioids. They use different types of not only medications, but sometimes they use radiation just for pain control. They'll use things such as, um, physical therapy sometimes to help. Massage therapy will help with pain control. Um, these patients also will have altered respiratory and cardiac function. Cancer can disrupt respiratory functions, the capacity of the lungs, and gas exchange. And these problems with respiratory function can end up being the cause of death for a lot of these patients with cancer. Surgery as treatment. Surgery can be used as a treatment. It's the oldest form of cancer treatment. It used to be all we had long before they had chemotherapy or they were using just cobalt and gamma rays, where they were pretty much just burning everything with radiation therapy in the early 80s. Um, Before any of that, they had surgery, and they would just remove as much of the cancers as they could. Now now surgery as cancer treatment can be prophylactic because of potential cancerous tissue. Um, it's usually collaborative with one or more treatments. Um, it can be controlled part of the tumor. This is called debulking. If the tumor is too spread around vital organs that cannot be removed, they'll try to decrease the size of the tumor sometimes with surgical intervention. A lot of times, surgery is done for palliative care to relieve symptoms, like we were talking about spinal tumors. They may remove some from that. A lot of times, if people have tumors on their lung, they'll take some times and debulk some of those tumors if necessary. There's cancer. A lot of cancer surgeries are moving more laparoscopically and robotically. Side effects of cancer therapy is anytime you remove even part of an organ, the organ loses function. Okay. There is scarring. There can be disfigurement, whether it's a mastectomy or I think more of the patients who are having who have jaw or tongue cancers and they're having really large areas of their face removed. That's what I always think of when I think of the disfigurement from cancers. Radiation therapy. I talked just briefly about that earlier, speaking that radiation therapy has been around since, and don't quote me, I feel as though it's been around since the late 70s. And they used very harsh rays at that point that pretty much burned everything in sight. And they were also doing implants very soon to that time frame as well. Nowadays it's much more localized. It's mostly ionizing particles, and so therefore the nucleus gets rearranged. Um, there are three types of energy used now. There's gamma is the most common type. Used to be, like I said, they started out with different types. Teletherapy sources outside the body. Teletherapy means that it's outside the body. This is like when someone goes for radiation therapy in the hospital and they have the radiation markings. Um, Bradytherapy is short term, is when the patients have the intermittent, when patients have the radiation implanted inside them. And I want you to make sure that you look at chart 22-1, and this is a need to know. It talks about the difference between the teletherapy and bradytherapy and what we need to teach patients about that. The amount of radiation delivered is called exposure, and the amount of radiation absorbed is called a radiation dose. Dose is always less than exposure. I'll say that again. The amount of radiation delivered is called exposure. The amount of radiation absorbed is called the dose. So therefore the dose is always less than the exposure. Three factors determine the dose: the intensity, the duration, and the closeness. Intensity decreases with distance. Cells don't all die at once. Some of the cancer cells, it takes up to 24 hours for sometimes the cells to actually die after they have been radiated. Radiation is given in divided doses and is given in divided doses over a period of time. Kills both cancer and normally rapidly growing cells. So just keep that in mind. I want to make sure, again, you need to know chart 22-2, skin protection during radiation, and the action alert on page 390 is also essential for you to know. Side effects of radiation therapy. They vary according to the site. Location, skin changes, and hair loss are likely permanent, depending on the total absorbed dose. Okay, so when a patient's side effects are from the radiation, a lot of times, unlike chemotherapy where hair loss is just temporary, because the radiation actually burns the hair follicle, a lot of times this hair loss will be permanent. Okay? A lot of times patients who have radiation therapy, no matter where the radiation is, they will complain of taste sensation changes. A lot of times they'll have fatigue related to increased energy demands. They'll have an inflammatory process that can cause tissue fibrosis and scarring. Please review again, I mentioned it earlier, table 22-2, acute and late signs of specific effects of radiation. Just be aware of what the different side effects are and treatments for it and what patient education we need to do. And remember, we want to talk about not using harsh soaps. We want to make sure that we talk about not removing markers that have been placed for radiation therapy. Okay. Nursing care of patients undergoing radiation therapy. Skin in radiation therapy path becomes dry and may break down. Teaching patients about skin care during radiation is a priority nursing intervention. Again, talking to the patients about skin care during radiation is a priority for nursing care. They're going to be told to avoid direct sunlight during the radiation therapies. They're going to have a treatment for, they're going to be treated for dry mouth. Bone exposure to radiation makes the bones more vulnerable to fracture. Um, Teach accurate, objective facts to help the patients cope. Don't give them unrealistic things or, you know, oh, everything's going to be okay when it may or may not be. And we've already spoken briefly about not removing the markings that are essential for the radiation therapist to be able to use during the radiation therapy. Sometimes they will have special skincare regimens. There is limited evidence based to support the use of lotion or ointments to decrease radiation dermatitis. Again, chart 22-2 is very important. But there is limited that using lotion or ointment to decrease radiation dermatitis, meaning that you would put it on prior to, that it actually is beneficial. Mostly it's skincare and treatment after the skin has already been exposed to the radiation rays.